A very good morning to you all. Obviously, have the therapeutic advances in the last decade has made difference to our life of our patients? Obviously, the answer to this question is yes. This is because the concept of diabetes has changed from mere glycemic control of glycemic triad, from HbA1c fasting postprandial control, to less glycemic variability, less hypoglycemia, less weight gain or maybe weight loss, and the most important thing which I feel is improvement in the quality of life. That's the bottom line when what we talk about. We will discuss all these we should understand what are the therapeutic advances which has occurred in last decade, so that then we can decide whether they have changed our life of our patients or not. Now, the basic understanding of pathophysiology of type 2 diabetes has changed from this triad to this ominous octate. This has implications in the management of type 2 diabetes mellitus. This is because the aim of management of type 2 diabetes mellitus is pathophysiology based management of type 2 diabetes mellitus. Similarly, the legacy effect which we have learned in last decade after publication of EDIC trial and extension of UKPDS has shown that early glycemic control in patients with diabetes, whether it is type 1 diabetes or type 2 diabetes, has prevent not only microvascular complications but macrovascular complications as well as and reduction in the cardiovascular mortality. At the same time, late glycemic control in in diabetes has increased the mortality as shown in Accord trial, and hence the glycemic targets which has been recommended are not only reduction of HbA1c 7, but we have to individualize the targets based on patient selection. Younger patients, tighter control. Older patients with comorbid conditions, looser control is acceptable, but along with that, most important thing is avoidance of hypoglycemia. Now, how do we avoid hypoglycemia? By individualizing the target HbA1c, and hence we say that our management should be patient-centered. The scope of antidiabetic drugs before 2005, where these are the antidiabetic drugs which are available to us, but limitations of these antidiabetic drugs were weight gain, hypoglycemia, fluid retention, GI intolerance. These are the major limitations of the all these antidiabetic drugs. Weight gain and hypoglycemia were the most important limiting factors while reducing HbA1c in the management of type 2 diabetes mellitus. This hypoglycemia was also associated with reduced quality of life, increased the healthcare cost as well, and Accord trial had shown that hypoglycemia is associated with increased mortality as well. Glycemic variability is another factor which is responsible for development of chronic complications of diabetes mellitus at same level of HbA1c, whereas less glycemic variability was associated with reduced complications of diabetes mellitus, and this glycemic variability was more with sulfonylurea and metformin. This has not only increased the morbidity but mortality as well in patients with type 2 diabetes mellitus. With the currently available antidiabetic drugs, we see that incretin based therapies or SGLT2 inhibitors, these are the drugs which are available to us. Now we will see what are the benefits of incretin based therapies. Incretin based therapies, these are the drug which has action based glucose dependent action, and therefore these drugs do not cause hypoglycemia. That's the major benefit. With reduction of HbA1c, they don't cause hypoglycemia. They have additional advantage of either no weight loss with DPP4 inhibitors or weight loss with GLP-1 analog therapy. And till date, all the antidiabetic drugs which were available to us has not changed the beta cell mass, but probably incretin based therapies, these are the drugs which has improved the beta cell mass. Obviously in animal studies, though we cannot have data in human studies. So, but obviously there is some drug which can probably increase the beta cell mass, which is the major pathophysiological defect in patients with type 2 diabetes mellitus. At the same time, these are the drug which acts on multiple mechanisms of the multiple pathophysiological defects in patients with type 2 diabetes mellitus. So in short, incretin based therapies, they improved glycemic control significantly by reducing HbA1c and its key contributors, fasting and postprandial plasma glucose. DPP4 inhibitor overall incidence of adverse event is minimal. They do not cause weight gain. They are weight neutral, lipid neutral. The GLP-1 analogues therapy can cause weight loss. They can be used safely in patients with renal or hepatic impairment. GLP-1 based therapies causes, GLP-1 analog causes weight loss and probably increase the beta cell mass. What about SGLT2 inhibitors? These are the drugs which act on the renal tubule and therefore they increase the glucose excretion. By increasing glucose excretion, these drugs improve glycemic control and reduce the microvascular morbidity. These are the drugs which causes weight loss. They decrease blood pressure. Since action is insulin independent, these are the drugs which do not cause hypoglycemia. And obviously, the action is independent of insulin, and therefore, these drugs can be used at any stage of the diabetes. Recently, it has been found that the combination of GLP-1 based therapies and incretin based therapies and SGLT2 inhibitors, if you see the combination of these two drugs, they probably act on multiple mechanisms. They cover almost all mechanisms of all pathophysiological defects can be targeted by the combination of these drugs. An elegant paper which has been published in March 2015 has shown that SGLT2 inhibitors empagliflozin and DPP4 inhibitor linagliptin as a second line of therapy for 52 weeks significantly reduce HbA1c compared with the individual drug and hence US FDA has approved this combination recently as a second line. So the major challenge in achieving good glycemic control could be achieved by achieving target HbA1c without hypoglycemia, no weight gain or probably weight loss. We have drugs like GLP-1 analog which causes weight loss. We have SGLT2 inhibitors which causes weight loss and DPP4 inhibitor, these are the drugs which are weight neutral. So these are the major benefits which definitely improves the quality of life of our patient in day-to-day management. Now moving towards the insulin therapy, we have moved from bovine, porcine, human to analogues. Recently launched insulin degludec it has long half-life and flexibility in dose timing. That's the major advantage with minimal risk of hypoglycemia with insulin degludec. That helps in our type 2 diabetes patients as well as type 1 diabetes mellitus. While monitoring, we have moved from SMBG to CGMS, especially in patients with brittle diabetes. We know that there are certain limitations of SMBG. SMBG cannot pick up the day-to-day variations which can be picked up by CGMS and which helps us in management of both type 1 as well as type 2 brittle diabetes. We have various types of CGMS devices which are available, standalone to integrated CGMS, sensor augmented pump therapy, and even insulin pump therapy has also helped us in improving the quality of life of our patients. Recently, a new insulin pump, Paradigm Vio, which has been launched in India, has definitely advantage of predictive alerts which has low glucose suspend option and prevent hypoglycemia in patients with type 1 diabetes mellitus. This has really changed the management of type 1 diabetes in our day-to-day practice. In short, to summarize, evidence-based understanding of diabetes in last decade has changed the therapeutic goal in diabetic patients, that has improved the quality of life of our patients obviously. Recent therapies, that is incretin mimetics, SGLT2 inhibitors, has definitely improved the quality of life of our patients with no hypoglycemia, weight neutral benefits with DPP4 inhibitors, and weight loss with either GLP-1 analogues or SGLT2 inhibitors. Newer insulins, insulin pump, and monitoring system has significantly made the difference in the management of type 1 diabetes mellitus. Thank you. Thank you for your patient hearing.